All right, good afternoon, everyone. And we have three panelists at the front of the stage. We're going to be talking with the Joint Commission today, and we're lucky to have Dr. Klaus Nether, who's the Director of Solutions Development for the Joint Commission Center for Transforming Healthcare. Prior to his role, he was a black belt in the Department of Robust Process Improvement at the Joint Commission. He supported the Joint Commission's activities associated with establishing and sustaining an RPI culture, including the use of Six Sigma, Lean, change management, and other performance improvement methodologies. Dr. Nether was responsible for leading strategic projects, providing expert advice to process improvement teams, and helping to develop and implement a quality improvement training program. Prior to joining the JC, Dr. Nether held a variety of clinical laboratory positions. Most recently, he was the manager of the Olson Clinical Laboratories at Northwestern Memorial in Chicago, where he was responsible for 6 departments, including the micro and molecular biology labs. We also have Dr. Kelly Reynolds up on the stage today as well. Dr. Kelly Reynolds is an associate professor in the Environmental and Occupational Health section of the College of Public Health at University of Arizona and director of the Environment, Exposure Science, and Risk Assessment Center. She has nearly 30 years of experience as a microbiologist in environmental health sciences and in directing research programs related to infectious disease transmission, microbiology, quantitative risk assessment, and public health policy and education. She's published over 350 journal articles, book chapters, and professional reports. Her and her squad specialize in development of methods for tracking pathogen movement in healthcare environments and evolving predictive risk assessment models for determining pathogen spread, human exposure potentials, and adverse health impacts and intervention. Finally, we have Dr. Chris Green on your left on the stage. She has over 8 years of experience in epidemiological laboratory research, holds a PhD in environmental health sciences, and a master's of public health and hospital and molecular epidemiology from the University of Michigan. Go blue. Her academic research focus has been on healthcare pathogen transmission, pathogen environmental survivor, and biofilms, which has led to multiple publications. At NSF, she has been making strides to improve public health in areas of infectious disease prevention and control in clinical and dental settings. Her research focuses on healthcare transmission of pathogens. Oh, I skipped a line there. I apologize, Chris. Anyways, you guys know Chris. We can stop there. This is a Q&A session, so they're going to pepper Klaus with some questions. I should put 2 ferns here. It could be a Zach Galifianakis kind of skit. But I'm sure you guys will do fine, and I'll get off the stage and let you guys proceed.
Do you have any disclosures?
Can everyone hear us? Yeah, I do have a couple disclosures. One, I just want to let everyone know I'm not a surveyor. I don't work on the accreditation side, don't work with standards. So actually, I work in a separate entity within the Joint Commission.
Okay, I'm going to start with a question, Kelly. So with your disclosure, we know you're from Joint Commission, you're not a surveyor. You are with the Center for Transforming Healthcare. Can you explain what that means, what that does, and how that's different than the Joint Commission proper?
Sure. Many of you know, especially those in healthcare, the Joint Commission as far as an accreditor. Since 2008, we have a separate entity. It's called the Joint Commission Center for Transforming Healthcare. And our work is really around performance and process improvement as well as patient safety. Our overall mission is to transform healthcare into a high reliability industry, no different than aviation, nuclear power, really with the goal of getting to zero harm. So we really work with healthcare organizations. Some say we're the good side of the Joint Commission. Don't know exactly what that means. But we really work with healthcare organizations driving improvement with especially focused areas, such as hand hygiene being one. We've worked on 10 other focus areas, such as handoff communication, reducing sepsis mortality, reducing C. difficile infections, as well as safe surgery. So those are just a couple of the focus areas that we're working on. And really the goal is not just working with what we call participating organizations, but then disseminating all those lessons learned to all our accredited healthcare organizations. And we do that through a web-based application.
And I was just wondering, Klaus, if you could talk more about why hand hygiene was one of the first projects of the JC Center for Transforming Healthcare.
Sure. So we worked with 8 participating organizations, well-known organizations, some we've heard of, Cedars-Sinai in California, Johns Hopkins in the Midwest, as well as in the South. We worked with Memorial Hermann, So we had 8 participating hospitals, but as we started to discuss what would be a focus area that we should all work on, hand hygiene came up. And it was very interesting, and I know one of the previous speakers talked about it. They were all around 90% compliance, except they didn't believe it. So as far as the
They
PI
didn't
folks,
believe it,
as
or
far
you
as the
guys?
PI folks that
Okay.
were working with us, they were kind of cautious about those numbers. They thought there was some bias within the measurement system. You talked a lot about the last previous speaker in terms of some of the bias because they were doing direct observations. My background in laboratory, I've seen it often because we actually had phlebotomists that actually reported to the lab. And it was interesting, the only accurate result we had was the first one in the morning because they didn't know infection control was on the floor. After that, they came down. Everybody knew, hey, today's hand washing day. So by the end of the day, we're in the mid-90s, right? So, they had some of those similar feelings in terms of, yes, we're reporting out 90, but are we really truly at 90? And the other part is everybody makes hand hygiene sound very simple, right? Especially when you talk to non-healthcare folks, they can't understand why people don't wash their hands. Should be really easy, right? Our mothers taught us to wash our hands, yet it is very difficult. It's very complex. So, you can go trace this back to the 1840s. A gentleman by the name of Dr. Agnes Semmelweis, many of you have heard of him, who actually proved that you can reduce mortality through infections by washing hands. Yet, we're in 2017, and organizations are still struggling with that. So they really wanted to work on that. The second piece was also in terms of sustainability. We've seen jumps, organizations have talked about it. We've seen improvements, we just can't sustain them. So how do we actually sustain them? So that was going to be a lot of the work that we were actually going to undertake, and that was why it was one of our first projects.
And so you also have, with your participating organizations, a systematic approach to this hand hygiene initiative. Can you tell us more about that?
Sure. We have about 27 participating organizations, including like Mayo, Cleveland Clinic, Kaiser Permanente, name some of the other ones like Cedars-Sinai that work with us. And one of the things they all have in common is what we call robust process improvement. It's actually a term that we actually coined at the Joint Commission Center for Transforming Healthcare. And it really looks at tools like Lean, Six Sigma, and change management and uses that blended approach in a systematic way to really start to identify within an organization what the root causes are. We don't see one approach better than the next. I mean, we hear a lot in healthcare, folks are using Lean, some folks are using Six Sigma, but we see each of these approaches as critical, important, because depending in terms of what you're trying to fix, not every tool is going to apply in that PI toolkit. But again, if you have then different tools, you're going to actually see robust improvements being made. The third piece of it is we hear a lot in terms of change management, because you're going to have resistors. We learned a lot in terms of working with organizations that, yes, people will complain to you about a process. It's broken. Don't like it. Work long hours because of it. Change the process on them. You know what happens? They become resistors. Why? Because they're comfortable working in that broken process. I know what I'm going to do tomorrow. I know what I'm going to do next week. Now you're changing it. It might be changed for a benefit, a value for them. But again, we're human. And as humans, we hate to change at times. So, having a tool set around change management, getting that acceptance and buy-in from folks, that really helps then in terms of the sustainability piece. Because at the end of the day, especially as PI experts, you're going to walk away. And if that doesn't become daily work, if that doesn't become embedded within that organization, within the culture, you're not going to sustain it.
What's the biggest aha moment that you've seen with participating organizations as they've gone through these hand hygiene initiatives?
Well, I think the first was the realization that they're not at 90%. So as they collected data, and we can talk a little bit about in terms of the data collection because that is always a challenge. As an aggregate, they ended up at 47.5%, far from being at 90%. So reality started to set in. This is what reality really looks like when people do not know that they're being watched, when they know that infection control isn't on the floor. So I always think of it very similar when we talk about monitoring and you have infection control folks. I think about when you drive on the highway. When you see the state police, everyone's going 55, if that's your speed limit.
Right.
When they're not there, everyone's going 85. So it's very similar. You have then that Hawthorne effect. You have that bias that people are being watched. We're going to act differently. By the way, I'm going to outlast you. You're not going to be here tomorrow watching me, and then I'll go back to my normal routine.
You were talking about the systems approach in previous answer, and one of the things that I've come across are a lot of healthcare, these department managers or directors, and they want to implement change, but because they want to make things better than what they currently are doing, right? Everybody knows we can improve, but they're afraid that it's not going to be better than what they're currently dealing with, right? So if right now is mediocre, we're going to go about this whole great big change, and I'm scared that it's not going to be much better than mediocre, or what if it's worse? And there's consequences for them on the regulatory or policy end. So it's a big, there's a lot at stake for them. And have you run into that? And how do you?
Yeah, I mean, there's always the concern that when we make a lot of change in healthcare, right? Happens every day. And does that change just result in a change of what I'm going to be doing, or does that really result in improvement? If it results in improvement, staff see the value and the benefit. If it's just the change for the sake of change, that causes a lot of dissatisfaction. So one of the things is, and we talk all the time about the change management piece, is, well, painting that future, what is it going to look like? Getting them to accept and buy into it. But more importantly, getting them involved. They have to be part of the solution. If they're not part of the solution, I can almost guarantee you, you're going to have failure because they're not going to accept it. Because at the end of the day, they're going to outlast you. And they wait till you are gone that day, and then they're going to revert back to their old ways. So change management is such a key piece, and we overlook it. Especially I was in a leadership level working in the laboratory, and I thought, whatever I said went. Well, it didn't. Because unless I was sitting next to them 24/7, they knew I wasn't going to be there certain times during the day. And they revert back to their old ways. So it's very key. How do you get that acceptance and buy-in? Thinking about who your resistors are, and then starting to really address that with some actions that you can take moving forward. But it is all about getting them involved. If they become part of that solution, you're halfway there.
I'm going to ask about the targeted solutions tool. Sure. Can you explain that to us? I'm not
Sure. So one of the end results is that we want to share those lessons learned as we work through the projects with our participating organizations. And we share that through a web-based application called the Targeted Solutions Tool, which is based on the fundamentals of Lean Six Sigma and change management. So they use that systematic approach to actually collect all their data, identify what their specific contributing factors are, and then based on those contributing factors, they'll have solutions that were validated and targeted to those specific contributing factors. So it isn't, we're going to throw the whole sink at it here approach in terms of implementing every solution. We know that that's not going to get you robust improvements. So we talk a lot about, with hand hygiene, it's supposed to be simple. Well, it isn't simple. It's very complex. We had over 41 different root causes that were identified. And that really kind of led through to really three key things that we found going through the project. And it's been the three key themes that we've seen with every project. The first is all these projects and these really focus areas we're trying to tackle, they're not simple. They're complex. The magic bullet, that one solution, doesn't exist. I hate to say it. We see it a lot in terms of organizations. You know what? There's a best practice right down the street. They've seen great results. Let's implement it. Guess what happens? They don't see the same results within their organization. Why? Because they don't have the same root causes. And that was part of those three key themes we saw. Is one, these are very complex problems. There are multiple root causes to a problem. 2, each of those root causes requires its own strategy, its own targeted solution. And then 3, the set of root causes differs not only from one organization to the next or from one setting to the next, but even within a hospital, we saw it from one unit to the next. Med-surg was very different in terms of ICU as far as what their root causes were. And sometimes when we implement those solutions, what we do is actually a disservice. Sometimes we have a negative outcome from it. We want to spread it. We saw this worked in one unit. Let's spread it to the entire organization. And one of the pilot organizations saw that, what they were doing. They actually implemented, and what they saw as part of their discovery process was that their dispensers were on the wrong side of the door. They had everything on the left side. They noticed everything came in workflow-wise on the right side. So again, out of sight, out of mind. If it's not in my workflow, I'm going to miss it. So they just simply moved their hand hygiene dispensers to the right side, compliance shot up. So what do you think their next step was? Let's spread it. Everybody who's got it on the left side, let's put it on the right side. Well, one of their newer units that was actually redesigned about 4 or 5 years prior had it on the left side for a specific reason. Their workflow came in from the left side. So they were about to move everything from left to right, and the nurse manager on the unit said, wait a second, why are we doing this? Because of the workflow. Well, our workflow is left. And then it sunk in, well, wait a second. It isn't that simple that we can just spread it. We have to have an understanding of each of our units. So again, it is difficult. There isn't that magic bullet. There isn't that one solution. It really comes down to understanding your process and what those contributing factors are, or root causes that are driving that poor performance in that area.
And I like how you've really outlined that, the perception is that these are easy solutions. And even when you say it could be as easy as moving your process flow in a different way, but the reality is these are very complex, non-generalizable concepts sometimes. And so the development of tools and having the support for organizations like yours and informing people on some of these practices and some of these projects you're doing, I think is very important. So what is kind of the process of informing people about what you're doing?
So with that, we disseminate all our information. We have a website that's dedicated to all our project work, as well as when we're ready with our Targeted Solutions tool, we disseminate that out to all our accredited organizations that they know it's available right now, and it's free of charge. They can use the tool. It's free of charge. It's confidential. Over the last 8 years, we've built a lot in terms of trust because we still have that word Joint Commission in front of the center, which makes it difficult for people to say, oh yeah, I just want to share all my data with you. So, we constantly tell people that we are separate. We do have a firewall. So in terms of us and the accreditation side has no understanding of who's using the tool, why they're using it, what their results are. As far as a surveyor finding out, that's really the disclosure of the organization to tell them that they're using it. We always encourage them to let the surveyors know as part of the process improvements that they're doing within their organization. But as far as with us, everything's confidential. And we've seen it also in terms of in the last couple of years, we've started to write publications around our work. We won't reach out to organizations to say, hey, by the way, you guys improved from 30% to 90%. Tell us your story. Because we do want to keep everything confidential because we want people to trust us in terms of data sharing. Because one of the things we do is we do aggregate all the data to disseminate it through publications. And actually, one hospital system, Memorial Hermann, who was part of the original participating, they had one hospital working with us, they actually implemented the Targeted Solutions tool to their other 11 hospitals. And basically, it is still direct observation. That was one of the challenges that we had is how are we actually going to collect data. And we had to look at the various different criteria, whether it was getting that representative sample, how many samples to collect, who will actually collect it. So our recommendation was don't use your infection control nurses. Actually, don't use any of the nurses. Use people that go through those areas but really don't have nothing to do with patient care. maybe the chaplain that walks around, maybe your security guard that walks around. Train those folks. Now all of a sudden reality started to set in, and they weren't at 90%. They were at 47.5% because they didn't know anymore who was actually watching them. We did go with the wash in, wash out because we know there were some difficulties in terms of doing all 5 moments, especially within the room. So if Christine went in the room as the nurse and I was following Christine, obviously, why is Klaus in the room with me? So people act different because there was really no reason for me to be in the room. So unless you had 2-way mirrors in each of the patient's rooms to actually then observe, we knew that we weren't going to actually get non-biased data. So there were some exclusions. We didn't look at the quality of the hand wash either. We just went simply with wash in, wash out. So yes, we could say that 47.5 is probably a little bit inflated as far as that. Could be a lot lower if we looked at the quality aspect and the other moments with that as well. But it ended up being at 47.5, and it was something that we could actually transfer then to other organizations using the tool as well. So as far as that, we do have a common standard of data collection when it comes to that piece of it.
So with just over 1 minute left, do you have any last, just a takeaway, an aha, our biggest challenge comment?
I think one of the biggest takeaways is you have to understand your processes. Other people have solutions, but it isn't as simple as just implementing someone else's solution within your organization. You have to first understand your organization first. And that sometimes will have to go even at the unit level. Understand at the unit what's going on, getting to what your root causes are. It isn't as simple as trying to take someone else's solution, someone else's root cause, and just applying it within your own organization. That's the first piece of it. And I think the second piece of it, as far as sustainability, it's something that you have to continue to measure and monitor moving forward and taking action at the first sign that you're starting to trend negatively. That's what Memorial Hermann did. They actually, for 24 months, kept their hand hygiene compliance above 95%. They are now reporting system-wide on a monthly basis 0 or near 0 across the whole system on their HAIs. They're collecting about 11,000 to 15,000 samples per month.
So near 0 HAI rates or, okay, well.
System-wide.
Thank you. Russ Armstead from Livonia, Michigan. Appreciate the insights from Joint Commission. I'm curious whether there's been any discussion at the Center for Transforming Healthcare around use of HAI data analytics and a crosswalk to accreditation status to see is there a correlation between, accredited with commendation and lower HAI. So that's part one. Part two is Joint Commission thinking about development of a certification program for HAI prevention?
So question number one, we haven't looked at that yet because we're still in the infancy of a lot of data collection. Currently, we have about 275 organizations, roughly about 1,300 projects now. So that might be something in the future we'll look at in terms of that. And again, as an aggregate to look at. As far as your second piece of it, certification side gets handled on the accreditation side. So we would be very separate from that being worked in. But there is now, in terms of the surveyors do let folks know within the organization that they do have these tools available. And again, even though these tools are free of charge, I would say probably we're at about a 3-4% of people actually using the tools. So there's a lot in terms of that. We're still working with awareness, but again, priorities within the organizations differ as well. Hand hygiene is not always the number one priority within an organization because there are so many other things going on, whether it's falls prevention, communications. So
these might be a little bit more observations of two things. Medicine is moving toward individualized care, individualized patient care. So why aren't we treating the employees the same way? I mean, employees don't want to be lumped into these. I called it this morning with one of the speakers. We're not trying to colonize people here. We're not trying to dictate to them. Now, there may be common things between different sites that apply, is what I'm getting from what you're talking about. But if we're going to look at individualized, no patient wants to come in and be treated like the last one unless there's something common to what the treatment's going to be. Well, neither does the staff. And then as a researcher, I'm observing that Kelly used the word, we're under a lot of pressure to generalize everything we do in a research project. And what is clearly being said here is that that won't work. So the research needs to look at a per site and then pull out the common threads that then might be applied to another organization. But if we go forward and fund research, we have to keep looking that these sites have individual cultures and individual things and individual solutions. And that's not acceptable in a university scientific setting all the time and in publication. And so we have to maybe re-educate some of that process to make sure that we can get studies coming forward that are actually going to lead to solutions, and not just saying, why is it that we don't have this thing that's generalizable when it's not, until we can get more individualized studies on this. So that's just an observation of, I don't know if anyone would want to comment on that, but that's what I have kind of heard there.
I just absolutely agree. I think that when you, first of all, for studies that you cannot demonstrate generalizability, you can't get funding. And even if you do have it funded and then you do the study, now you are going to have a really difficult time getting it published. So there is a mindset there that really does need to change.
And I think some of the approaches we're using in academic research is developing, like you are, the tools. So if we can develop models that can define some of these environments, so mathematical algorithms where you can enter your own data for your own facility and run it through some of the common themes that link those different variables, but yet you have your own unique information that you input into the model. And so I'll talk a little bit more about that this afternoon, how we're using that approach in HAI reduction.
And just to add on, I totally agree with you in terms of even with our publications, we run into that as well, because we're making publications off of our PI projects, and we get asked, well, what are the generalizable solutions? Well, we don't really have any generalizable solutions. Well, maybe we do. The generalizable solution is that systematic approach that you can use, but again, at the end of the day, what you're going to get as an outcome is you're going to get different root causes that you're going to see. But I think the approach is what could be generalizable, that could be used within healthcare to say, okay, we need to really look at our own processes, have a better understanding of our own processes and what's causing poor performance. And then with that, target our solutions towards that.
Well, thank you very much, panel. Great presentation. This isn't so much about Joint Commission as some of the topics you were bringing up, and mostly regarding hand hygiene. That's a continuing theme, a continuing example here. And you had mentioned Semmelweis, and everyone in IPC knows that Semmelweis is responsible, for starting the trend towards hand hygiene. Outside of infection prevention, though, Semmelweis is really known for being a smart guy who had a new idea that nobody would accept. And he went to his grave kicking and stomping and, 20 years in a madhouse trying to get people to listen to him, to look at the data and do something new. And it's called the Semmelweis reflex. So everybody outside of infection prevention would look at that aspect. And I would encourage us all to look at that great contribution that he made, look at things from a new approach. And one of the comments that was made at the previous presentation by Elaine was, it's not the process, it's the outcome. And I think that's a gap that we have in hand hygiene. It's a great start to look at the 5 moments. It's a great start to look at how we wash our hands and when we wash our hands, et cetera, et cetera. But that's prescriptive process. We're not looking at the outcome. The outcome could be what is the level of contamination in our hands, or what is the rate of transfer to patients. But until we start looking at that as well as the process, we're not going to get a revolutionary innovation in that space. It's just going to be evolutionary. So we need to be outcome performance-based with validated measurement so that we can look at alternate ways to do things, et cetera, et cetera.
Yeah, I would build on it that I think it's two-sided. You have to have the outcome as well as the processes within, because those are the things you're going to look at to try to change, so then your outcomes change. So I think they go hand in hand. I do agree. I think, we need to define in terms of what those outcomes look like to get us maybe at a more significant level of improvement. But yeah, we're not there yet.
Any other questions? If not, can we give our panel speakers a hand?